We do have Dr. Robert Bard with us, and he is the director of the Bard Cancer Diagnostics Center in Manhattan. Dr. Robert Bard, we're so happy to see you today. I'm going to get your slides for you right now.
Good morning, Sherry, and thank you so much for the invitation. Well, I guess it's good afternoon now,
Yes,
depending on your time zone.
definitely. And there we go.
Let's start with imaging. I've been working with cancer imaging for almost half a century, and we've learned a lot of different things. When we started with ultrasound, we were able to see many things we didn't know what we were looking at. And then we were able to take pictures of, say, babies to start with. So finally, after looking at babies, we started looking at uh, the uterus, then we looked at the breast, and then the abdomen. And then we got into vascular imaging specifically because the blood vessels are everywhere in the body. So you have a map of whatever's going on. And then we are able to look at normal versus abnormal vessels. Why is this important? Because normal vessels are smooth and they're the right amount in a certain area, whereas cancer neovascularity is very important because this is a quantitative measure today of tumor aggression. Let me repeat that. Because we've learned in the last 20 years that as tumors start dying, sometimes they swell with benign fluid as they degenerate. Using the vessel density is better or more accurate many times than the size of a tumor. Let me repeat that. Sometimes tumors get larger as they're dying, and we have ways to measure this, specifically using neovascularity and measuring it with 3D, 4D ultrasound, so it's quantitative. Once again, the vessels are penetrating, they're irregular. You see a lot more vessels in the area. In other words, you see this many vessels instead of that many. This has been validated since the Italians did it in 1994, and we presented this at the World Conference in Austin earlier this year. Next slide, please. The beauty of using the vascularity is when you treat something, it goes from this many vessels and you kill it, and then it either slowly or very quickly disappears. With focused ultrasound, it's called HIFU, high intensity focused ultrasound, the vessels die immediately as you're doing the treatment. And this has been done for the last 30 years worldwide. Radiofrequency ablation also has been done for many years. Cryosurgery is also immediate. It freezes the cancer. Now, we tried to do other things. Of course, we were looking at radiation therapy, and this took time. Hormones take usually a little longer time. We did try something in France. There was a study using antioxidants because herbs heal. Do they treat? Yes. Do they cure? Maybe, but at least we have a way of following the progress. So if it's going from a lot of vascularity to less vessels in a tumor, you're at least making progress. So if it's going from, one vessel to this many, stop the treatment. Stop what you're doing. Try something else. Next slide, please. Here's where the vessel imaging is really, really important. So where do you biopsy? Specifically, we talked about tumor regeneration as it dies. Here's a perfect example of this. This is a breast cancer with a mass in the axilla. We want to figure out where do we rebiopsy the area. You have two options. You have the top of the mass or the bottom of the mass. As you look at the top of the mass, you see a lot of red tumor vessels. They're irregular, they're focused in one area. When you do the 3D, 4D ultrasound to quantify it, which is on the right side, we see that the graphs that show up that calculate the 100 pictures you take in 5 seconds, it calculates 27% vessel density, whereas the one on the bottom, the dark area, the vessel density is 1%, meaning it's all dead cells over there. If you put a biopsy needle into the dead cells, you'll get inconclusive biopsy. If you put it into the cancer, you'll get much more valuable information. Let's look at the next slide, which will show the obvious nature of cancer with high-resolution ultrasound. On the very top, you see some stripes on the area. This is the skin. That's the first thing we look at when we scan. We want to see how good is your ultrasound image. So if you see the skin clearly, you're getting good imaging. On the white side, this is benign breast tissue. The lobular cancer, which is a huge black irregular area, was missed on this patient's mammogram and MRI. Next, please. So treatment success. This patient was done in December, treated. Notice that while it's hard to see the red vessels on a single picture, the 3D ultrasound gives you a whole volume of the tumor at once. Now, this is important because if you're treating something, you can take the volume of the tumor and stick the ultrasound 3D information into a MRI machine, and you can guide needles to go right into the area that's aggressive. So you have a way of doing image-guided treatment at the same time. Let's go back 5 months later. The vessel density went from 4.5% down to 1%. The tumor, of course, changed with the radiation, fibrosis, and the scarring and dying. Once again, we have a nice quantitative, easy way of doing it for almost any cancer, but particularly breast cancer, because the probe is right on the skin. You take it and you take the pictures right away. Plus, since the imaging is virtually immediate, you tell people what's going on. This is what's happening now. So the treatment is working or not working. People want to know, where am I now? And not guessing, and certainly waiting, as the last lecture explained. If anxiety is not good for cancer healing. Next, please. Once again, we have a beautiful top left scan showing you the skin of the good side, and the left nipple. Visually, you see there's something on the patient's skin, but notice the ultrasound shows a huge wedge-shaped area of black. With melanoma, the second you put the blood flow on, it lights up like a light bulb. This is how we tell how aggressive, say, a melanoma is, or almost any cancer. The more blood vessels, the more aggressive. And this is used specifically in melanoma skin cancer detection globally to tell the patients how aggressive the melanoma or any other cancer is in the moment. Below that, you see 87.4 Fahrenheit This is thermal imaging, which is non-invasive. We have a way of seeing what's going on in the tissues non-invasively after being cooled off for some time to equilibrate the body, to make sure the heat coming from the tumor vessels is better imaged. You put the thermal imaging on and see a white spot, a white band above the left nipple where it should be dark like it is on the other side. So this happens to be a metastatic melanoma in the breast, which is very common in people. Other than primary male breast cancer, metastatic is certainly a big problem because it's extremely common in melanoma, which is getting increased in disease progress, increased in incidence worldwide. It's increasing just like male breast cancer is. They're both following the same path of increased incidence, and perhaps this is related to environmental causes, which we will discuss in the next slide. So here's an example of image-guided treatment. We see it on the left side, the arm is up, and while it looks like a secondary breast tissue, it's not. This is a massive 5 centimeter benign tumor. We see it's benign because the white lines on the top show the epidermis, and then below that is the dermis, and then we have the muscle below that. And just above the pectoral muscle sign, we have something showing the boundary of the fascia of the chest wall. So this is subcutaneous and not invading the chest wall, which is a good way to see it's more likely benign or not invasive. And then we have a beautiful 3D sonogram. Next slide, please. This is one of the many ways of ablation. Ablation has been used for the past 40 years now. This happens to be radio frequency ablation. Like I said, when you have the 3D picture, you know how wide it is, how deep it is, which guides you where to place the needles for ultimate thermal ablation and destruction. This has been done with high intensity focused ultrasound, which we started off 30 years ago. And now we are using focal laser ablation in addition to this. People can freeze this also. There are many ways to kill tumors, but this simply happens to show image-guided radiofrequency ablation of a benign fatty tumor. Next, please. Now staging. What do we do? Here's a patient with breast cancer, and there's a lump in the arm, and you feel that there are three glands that are suspicious. The blood flow technology shows you which of the axillary nodes is malignant, because in this case, out of the three, there's only one positive one with a high vessel density, and all the rest were not abnormal. And of course, the PET-CT scan shows the node there. What we are able to do, because once you see it, we can stick a biopsy needle in and sample the cells just to confirm, or you can stick a laser needle in and destroy it, or any of the other focal treatment ablative technologies. They all work. It's a surgeon's choice and patient's choice, of course. Next slide, please. So that's one of the problems with imaging, too, because if you have an implant or silicone anywhere in the body. And by the way, men are getting silicone in their cheeks, in their jaws, uh, everywhere in the body now. So when silicone ruptures, and it does often, this just happens to be from an implant, when silicone's in the body anywhere in the tissues, it can migrate, and in this case, it commonly forms granulomas, which shows up nicely. But granulomas show up on PET scan as an abnormality because it's not normal tissue. We see this with fillers in the face all the time. People will come in for, glands in the neck, and you ask the patient, well, what's going on? Have you had what kind of treatment have you had? Or are you exposed to toxins or parasites, which are an increasing problem also these days? Next slide, please. So false positives, here's a really important example because a lot of people now for inflammatory disease like rosacea and psoriasis, they're on biologics, which is great, but we all know that there's a slight risk of cancer from taking treatments. We have a large football-shaped area. Let's look carefully at it because the surgeon from a university hospital said, tell me it's a benign fatty tumor. And on first look, it looked like a benign fatty tumor. But when you look carefully, you see, first of all, the borders are irregular. And then on either side, it's sort of extending and pushing out the boundaries. What we do easily with the blood flow technology is put the blood flow on and say, oh, guess what? It's filled with abnormal vessels. This happened to be a follicular lymphoma, which is one of the complications of being on biologics. That's in the packaged literature. It says lymphoma is one of the possible side effects. More importantly, we see that if you try to biopsy this, it's connected to vessels coming from the aortic arch. This alerted the surgeons. If you go back to the first image, if you look more carefully, there's a lot of information in every picture. We see that the skin is not violated, so it's subcutaneous. We notice that there's a lot of red arrows. This points to the aorta, which we didn't notice until we did the blood flow study. So you can go back and forth learning from each technology as it gives you a lot of information that's reusable. Next, please. Okay, what's going on? Bilateral mastectomies, bilateral lumps. Guess what? Suture granulomas occur. And we're seeing reactions from now metallic clips. They're reacting, the metal is degrading and forming granulomas or even toxic disease in some people now. We've been looking at this. So this is not a recurrence. It's not a lymph node. It's not a metastatic site. It's a benign granuloma in the chest wall. And on the other side, because once you do surgery, when it heals, you get fat necrosis, and the healing often calcifies. So there's a white line called calcium, and below it, since calcium blocks ultrasound, you see a dark shadow, which is called the sonic shadow, which is key to looking at and finding cancers in different areas, because cancer is hard tissue, it absorbs the sound, and it leaves a signature that we call sonic shadow in this case. Next, please. Unfortunately, this fellow had pain in the rib. He was worried about having a rib fracture since he was a sailor. But while ultrasound doesn't penetrate through bone, when the bone is diseased and turned into permeable tissue, the ultrasound will go through. This way we look at the metastatic focus and we say, first, it isn't a fracture. Ultrasound sees rib fractures in second because there's a discontinuity of the bone. The patient puts the probe on the rib, and normal rib is like this, and a fracture is like that. So it's really obvious because the patient's yelling you at you at the same time. This quantitative imaging. It shows a high vessel density of 40%. Quantitative, quick, easy. You get the answer immediately, and you've saved more X-rays or other invasive procedures. Next, please. All right, non-palpable cancers. Well, this is a big one. This is 4 centimeters, and we couldn't feel it for various reasons. Either there's cystic breast, or there's surgery, or there's an injury. Look at the blood vessel findings. We have a lot of red and blue arteries and veins that shouldn't be there. And as I pointed out, the sonic shadow indicates there's a huge tumor going down to the bottom of the screen. So this is big. And again, this is non-palpable. So what's easy for people to do is get screened. We can put the ultrasound probe over the chest in less than a minute on each side. So we're able to scan for people who aren't sure or just want to get checked. We have ways of doing it simply. So there's thermal imaging, which could show this. There is blood flow imaging. We have other technologies, which I'll show in a few minutes. But let's go back to the top of all those red and blue dots. Notice the skin. See, the skin goes from being a homogeneous line on the top to getting very fuzzy and gray near the logic Q sign. This means the cancer, while you couldn't see it or feel it, or maybe that's the reason you couldn't feel it, it's infiltrating the skin. This changed the staging because you see it's already invaded the skin, so it's aggressive. Next, please. Okay, interval breast cancer. We've known this for, I'd say, the last 20 years now, but people never thought about it because it wasn't a common occurrence. But we started seeing it now that we have better imaging technology. So this happens to be a lecture at NYU, where we're noticing that 20% occur within half a year of a normal ultrasound, mammogram, or whatever study. This is important also because when they reoccur as interval breast cancers, they are more aggressive. That's why they occur in the interval. More aggressive means you got to find it early. So again, let's go back to screening and see what we can do. Next slide, please. All right, so here's an interval cancer. Patient had cancer on one side, and of course, they have a much higher risk of developing cancer on the other side, on the contralateral side. So this happens to be let's look at the left slide, which shows the microvascular imaging. This is advanced blood flow imaging, and it shows you have a normal tumor flow in seconds when you put the probe on. The patients see this. They say, what's that, doc? Then in the middle, you have the little white dots, which are the microcalculi, which you see all the time on mammography. So this would generally show up on mammograms. Then on the far right, with all the red and green colors, we have a non-invasive technology called elastography. And this shows you how likely things are to be aggressive. So it's quantifiable too. There's a Tsukuba score 4 out of 5. So it's suspicious. There was no mass. There was just some fullness. We biopsied it. It was cancer. Next, please. Okay, side effects of treatment. Notice how the white skin dips in with a huge black area, radiation fibrosis. There's something also called radiation edema, which you see it's also so black, but it's different because the fibrosis on the elastography is looks like scar tissue, and edema looks like water because it's fluid. So these are ways of seeing what's going on. And let me point out that when the skin is irradiated, when the breast tissue is irradiated, it's hard. You can't do mammograms. Sonograms are hard, but the blood flow and the thermal technology are non-invasive, and they basically see cancers through the scar tissue if there is. Next, please. All right, benign tissue, very common. So people are worried. What is it, doc? And we say, well, you can see it's a big area, but it doesn't look like cancer. It didn't show up as cancer on the other things. This is the common type of benign male breast tissue, which is occurring in men because as they go on high blood pressure disease or high blood pressure treatments or uh, cholesterol treatments or any of the new treatment technologies they're getting, they often develop benign disease. Now, this was a European fellow during the COVID area. So what else can you see? When you go to the bottom of the ultrasound picture, we looked at his pleura, and guess what? There was pleural thickening. The guy had COVID, so he said, please put on that mask tighter. And he just didn't say he had COVID. He was worried about his breast. So next slide, please. There's basically a lot of information in the ultrasound that is there if you're alert to it. This is one of the main uses of elastography, which was started in America, actually in Chicago, half a century ago, by the laboratory that invented the atom bomb in Chicago. So the physicists there were looking at sound waves too and said, see, what can you do with this? Well, as you measure the speed of sound, guess what? When tissue is fibrotic or cancerous, it blocks the speed of sounds. That's why you see the sonic shadow. This is a way of quantifying the sonic shadow because we are using it to see cancer tissue. And in this case, the malignant lymph gland, the part that's cancerous, shows up as a bright red focus. Of course, you can biopsy this, and when we do the blood flow ultrasound, it lights up again with blood vessels, and this showed up on the thermal imaging, which is why we got to it. But elastography is a non-invasive way of avoiding biopsies. This has been used in the skin, the prostate, the thyroid, and the breast for 20 years globally. So we have ways of possibly saving people from biopsies if they don't need it. Next, please. I want to end with the future. What else causes disease in your body? What's a precursor to cancer? We know that there are genetic components to it. There's trauma, but there's also toxic exposure. So how do we measure this now? Blood tests are an obvious way of checking for mercury because this is a blood test showing super high mercury level. Except this is not a blood test. This is me because I was exposed to mercury and some toxins in the military. And this is my blood test was positive 30 years ago, but now it's showing in the tissue. So using blood to show toxins, it's in a moment, so to speak. And in the urine, it's a day or two. And in the hair, it's a couple of months to see if there are toxins in the body. But in the tissue, it stays in the tissue for a long time. This is a simple way of seeing tissue toxicity that shows up that won't show up any other way. So now you have a way of taking a 5-minute test, a light spectral imaging technology. You put it on the hand or the foot or somewhere else. You take the pictures and you get a graph like this in 5 minutes. And you tell the patient, well, maybe we should go and check you for male breast cancer because men need a little push to go in for breast testing, and for mammography, they need a heavy push. But this is an easier way to get men to be, say, compliant with getting getting checked. So at this point, I'd like to say we have many additional ways of doing imaging with microscopy on the skin using optics. So this is all non-invasive technologies. Ask your doctor. Doctors say, what else can I do? Because it's around and it's being done somewhere in the world.
Dr. Bard, thank you so much. And for those who do not know or do not follow us on social media, Dr. Bard so graciously opened his office for the month of October for free cancer early detection screenings for first responders and for men to find out about breast cancer and other cancers. So we thank you very much for that. And I do have a couple questions for you in the chat. How can cancer be missed by mammograms or MRIs? And why does ultrasound sometimes find what other studies missed?
Thank you for that question because this is how I got started. 40 years ago, I was working with the top mammography cancer surgeon in New York, and he was tearing his hair out because you could feel the lump, the mammogram would not show it. So in dense breast tissue, the ultrasound sees it very, very well. As a matter of fact, we've taken their ultrasound machines and given it to college campuses, and the young ladies were putting it on their breast, and they would see benign tumors, and it was one cancer, but they would also bring their boyfriends in and scan them, which is a segue to getting checked now because the when you have things like toxins in your body, the women are who get tested, they say, let my husband come in. The same thing with the treatment for scars. When we're doing scar treatment with special electronic technology, we did it with the Canadians. The people who came in for scar rejuvenation or scar softening with simple medical electronic equipment, they came in for their C-section scars, but they brought their husbands in for their male breast scars. And we did it. We did it on them and we softened the scars. So people worry about scar tissue. There are ways of decreasing it by, first of all, knowing how deep the cancer is, and also by treating it with various softening technologies that we have to make the scar tissue less or heal better.
Okay. Why do some scans show false positives? And how would you confirm whether a finding is actually cancer or something harmless?
One of the reasons we stopped doing breast MRI about 20 years ago, there were too many false positives. As a matter of fact, MRIs have so many false positives that worldwide they've been changing the use of gadolinium, saying you can see 99% of the pathology in many tissues without using uh, gadolinium, which is toxic in the body. So we've refined our technologies, and if there's inflammation in the breast or anywhere else in the body, the gadolinium picks it up because it's too sensitive. This is a problem. There are many, many false sensitive MRIs, and what we do is we use our elastography, our ultrasound. So false positives are a fact of life with any of the isotope tests, with the MRI imaging tests. We have ways of double checking what's going on and why.
So the ultrasound is actually a little bit more effective, you would say?
It's not only ultrasound, it's ultrasound, blood flow technology, elastography, focal focal thermal imaging on the area. So all these are combined to reassure doctors and their patients that this is probably not serious.
Okay. I have another one for you. If cancer spreads to areas like the rib or lymph nodes, how does advanced imaging help doctors track recurrence or metastases earlier?
Advanced imaging. As we showed you, the rib metastatic lesion and even the axillary lymph nodes and the glands to the in the neck, metastatic foci, show up with the thermal imaging because they light up. A lot of blood vessels, things light up like a light bulb. The same thing on the vessel imaging with the ultrasound, the tumor vessels. We have such advanced technologies now that really the blood flow is, we have about 10 different technologies just to look at blood flow in tumors now. So this is being done.
Wow, amazing. And I know you mentioned toxins yesterday, and this is a good question for that. How do toxins, inflammation, or past medical treatments affect imaging results? And can this influence cancer behavior or risk?
Yes, from 9/11, which is a few blocks from where we are right now, and the toxins in the air and the exposure, what you breathe, what you got in, it forms cancers. We know that. Matter of fact, it causes, I think, 69 types of cancer. So toxins, first of all, they get into your body and they work on your immune system by decreasing it because it affects the, say, the thyroid gland or the parts of the body that are needed to keep your hormone levels high and your immune system working. We are also looking at boosting the immune system and decreasing the effects of chemotherapy and other cancer therapies with bioenergy treatments. Bioenergy using either near infrared laser, in others red light laser, which is simple, you put it on the skin, or pulse electromagnetics, which has been used on the astronauts since they first came down from the moon with osteoporosis. So the all these bioenergies, either red light laser or pulse electromagnetic, all these things regenerate tissue and they boost the immune system, and of course they decrease the disease, the side effects of chemotherapy and other treatments that are very hard. Plus, it improves wound healing in tissues.
Okay, I have one more for you. I was diagnosed with male breast cancer in 2019, and it was discovered that I had the BARD1 mutation. Given your last name, my guess is that your research might have originally identified this mutation. Is that correct? And if so, is there any new information about this mutation that I should know?
We have a whole genetics team, and yes, genes are very important in seeing what your what your risk is. So they're very good for measuring risk, and that's a whole separate department we have. So we have people who answer that question better than I do. And no, I will not get the Nobel Prize for the BARD
For the BARD gene.
for the BARD gene, but I repeat, we have ways of finding it before it gets aggressive and becomes a problem, ways of treating it with minimal scarring, and just better treatments now that this is all available. So men, don't worry about going into a mammogram facility with 50 women looking at you. You're not alone. There are ways to do it in the office. We sent these out to firefighters. There are portable ultrasound units that can go and you can put the thing on on the breast and see if there's something bad going on. We did this during the COVID area when everybody was locked down.
Mhm.
We did this for the firefighters. So all this is available. Ask your doctors what options there are, and He will tell you the genetics people to speak to about the genes, but the important thing is not are you, if you've got it, knowing that you're exposed to it and have a higher risk doesn't mean anything because you've got it. Find out what it is, and if you're at risk, more at risk, get checked more often. It's simple.
Yeah. Well, I thank you very much for your time today. And I'm sorry that you're not getting that Nobel Prize. It was a good question, though. Well, thank you, Dr. Bard. I appreciate your time. And I do have my next speaker on board.
Okay, great. Thank you.
Thank you.